Good afternoon. We'll get started. Thank you, everyone. I'm Wendy Rowe, and I'm president and CEO of Rosalind Franklin University of Medicine and Science. And it's really my pleasure to welcome you to the 8th Annual Women in Science and Healthcare Symposium. I think it's important that we have a program that highlights how women experience the greatest impact of climate change, right? And our students really want to know about this. Our students come to us with ways of looking at the world that are different than ways I looked at the world when I came to undergraduate. And they really understand that we're one world and that they want to protect the planet. And I think we have to honor that, and we have to make sure that we're giving them curriculum that relates to the world. They're seeking information and perspective on this climate crisis that they can take to their clinical practice, they can use in academics, and that they can use in research and in their personal life. I was telling our esteemed speaker, Dr. Sorensen, that this morning I was listening to CNN, and I guess I don't know if anybody else heard this, but they have 9 indicators that if all 9 of these indicators happen, then our Earth is not a habitable place. And apparently we are in the danger zone for 6 of these 9. So, and one of them is biodiversity. And I guess the biodiversity part, we're just like really in rough shape. And so this was, I woke up and I was listening to the news. I said, oh, this is really something related to what we're talking about. So it's a serious crisis, and it's important for us to be talking about it. We have the opportunity as a university to incorporate environmental best practices and concepts across our curriculum, across our discipline, and across our campus. And we need to put this into our personal and professional life and in decision-making as part of lifelong learning. We know that the environment poses a serious threat to human health, especially among low-income communities, pregnant women, and children. I'm sure we'll talk about that today. And so many of our public health issues, like the COVID crisis, are related to inequities in environmental health and other things. So that compels us to work for change, to drive a sustainable environment, to use innovation in all aspects of this important topic. We're intensifying our efforts to confront this complex effort in a collaborative community. And I'll say it now, but I told my cabinet that I want our next strategic plan, which is coming up, we're talking about it, to have the topic of sustainability. And not just environmental sustainability, but sustainability of the university, sustainability of our IP culture and our excellence. So all of our the things that we're embarking on will be about that sustainability. So this is just a great time to have this and to introduce it. So thanks again to all of you, whether you're here in person or virtually, to be present for this very important conversation. And my thanks to the excellent WISH Symposium Planning Committee. You always just knock this out of the park, who are organizing today's presentation. So with that, I'd like to turn our program over to the WISH Symposium co-chair, Kristen Jenners-Burgess, who I've known for a long time. When I was CHP dean, she is in CHP. She is the co-director of, she's served as the PA director of didactic education for the past decade. And her recent research projects include topics in breastfeeding, medicine, spinal changes in pregnancy, and team-based learning. So thank you. Thank you for doing this.
Thank you, Dr. Rowe, for your wonderful welcome and your steady support of the WISH Symposium over the years. It's my pleasure to further welcome you to the Rosalind Franklin University of Medicine and Sciences 8th Annual Women in Science and Healthcare Symposium. I, along with my co-chairs, Drs. Lise Elliott and Susie Calkins, are excited for this year's symposium and seminar series theme, Mother Earth Under the Microscope. Our WISH Advisory Committee discussed a number of themes for this year, but recurring topics were climate change and maternal morbidity and mortality. Eventually, our committee decided to merge these themes, hence the Mother Earth title. Today's symposium will focus on climate change and women's health, and our upcoming seminars later in this academic year will center around global maternal morbidity and mortality, as well as the treatment of women in relation to a culture's view on climate change. When we finalized our theme near the end of this past academic year, we knew our topic of choice was important, but it quickly became timely. Weeks later, we saw devastating climate change disaster after devastating climate disaster, from wildfires in Canada that brought smoke to much of the United States, including our campus in North Chicago, to recent flooding in California, to scorching heat waves, to devastating wildfires in Hawaii, to multiple hurricanes and typhoons, and now the catastrophic floods this past week in Libya. During my preparation for speaking today, I reflected on the source of my passion for conservation and sustainability, particularly pertaining to our Mother Earth theme. There were some obvious reasons. I'm a mother of 2 small children. I'm a PA focused on women's health. I'm an animal lover, and I enjoy time in nature. But I also realized that I grew up as a conservation kid in the 1990s. My generation of elder millennials saw recycling programs added to our schools, the introduction of dolphin-safe tuna. We constantly heard about the hole in the ozone, and we grew up watching Captain Planet and Free Willy and Ferngully. Saving the Earth was ingrained in us. I then thought of the adults in my life, as at the time I was a preteen and teen, who really hammered home the importance of making sustainable life choices. And 2 educators stood out in my memory. One was my 7th grade science teacher, Mr. Clemens, and the other my high school AP biology teacher, Mr. Stanko. They made learning, science, and conservation fun and exciting, from laboratory exercises to classrooms filled with items from nature to hiking field trips. Similarly, I believe we as current and future medical providers and healthcare professionals and healthcare educators have great power to influence our patients, students, and trainees to make sustainable choices, both in medicine and in life, through role modeling and education. And now it is my pleasure to introduce our keynote speaker for this afternoon. Cecilia Sorensen, MD, is Director of the Global Consortium on Climate and Health Education at Columbia University, Associate Professor of Emergency Medicine at Columbia Irving Medical Center, and Associate Professor of Environmental Health Science at Mailman School of Public Health, Columbia University. As a physician investigator at the nexus of climate change and human health, translating research into policy, clinical action, and education to build resilience in vulnerable communities is the focus of her research. Her recent works have spanned domestic as well as international emergent health issues related to climate change, including extreme heat, degraded air quality, extreme weather events, emerging infectious diseases, women's health, and worker health. Dr. Sorensen is a member of the Lancet Countdown on Health and Climate Change, and serves on the National Academy of Medicine's Action Collaborative for Decarbonization of the U.S. Health Sector. She is the co-editor of the textbook Climate Change and Human Health: From Science to Practice. Dr. Sorensen's keynote today is titled Rethinking Women's Health in a Changing Climate. Please help us welcome Dr. Cecilia Sorensen.
Thank you so much for the introduction. I'm so excited to be here today with you, and I'm honored to be part of this keynote. This is an exciting time to be talking about climate change and human health. And although this topic is heavy, and I think what we're going to be doing today is confronting a lot of uncomfortable truths. And I want to prepare you for that these are uncomfortable truths. As President Rowe recognized, we are facing some really difficult issues that affect our health and affect our communities, affect civilization globally. But with that, we have to have innovation, we have to have hope, and we have to have courage. And I think that those are key characteristics of the health profession. We deal with bad prognoses often, but we never give up hope. We never say there's no treatment options. We always have some type of way forward. And so what I hope today is that we can confront some of these difficult issues and think about ways forward. So with that, I have no disclosures. So I want to start out with a little bit of framing here. And I like this quote. We are living in unprecedented times. And I know there's some historians in the room. We are living in unprecedented times. And it said that we are the first generation to feel the impacts of climate change, right? We've known about climate change for a long time. We're feeling it. And we're also the last generation that can do anything about it, right? This has been a rapidly accelerating crisis that we are opening our eyes to more and more every day. And we are also the generation that needs to figure out where we're going from here. So when I was growing up, I think we were in a similar era, it was the polar bear on the iceberg, right? This was the poster child for climate change, and it's super sad. But more and more, we're seeing that the poster child of climate change is children, is women, is people living in vulnerable communities who are having their health directly affected by climate change. And so what a lot of our work is doing is shifting this lens. Because one, it's a reality, and two, as we frame climate change as a health crisis, which it is, we hope to break down political differences so that we can start working collaboratively together towards solutions. So there was a report which came out from the Intergovernmental Panel on Climate Change. This is a massive report that is produced roughly every 4 years. It's a 3,000-page report. Luckily, there's an executive summary. But if you didn't get a chance to read it, I want to review a couple of the main findings for us in the room, just to kind of orient to what is our best science telling us about where we are today with climate change and health. So the first key finding is that the climate change impacts on health are happening now. This is not something that's going to be happening in the future. We are dealing with this on an everyday basis. I see that as an emergency medicine doctor. Just last week, I took care of a 92-year-old man who had heat stroke and almost died. It wasn't even a heat wave where I was practicing. It was just a really hot day and he had no air conditioning, right? But we're seeing unprecedented heat, and the health impacts of climate change are happening now. So the IPCC report looked at 11 categories of diseases and health outcomes, which together comprise 70% of global mortality, and found that all of them are influenced by climate change. So because of increased heat, degraded air quality, more extreme events, resulting forced migration, all of these conditions which we treat on a daily basis, cardiovascular disease, diabetes, respiratory disease, infectious diseases, malnutrition, overnutrition, are being impacted in some way by climate change. The other thing we know is that the impacts are happening around the world. And what we're looking at here is observed impacts on human systems. So the key here is that the darker the circle is, the more evidence or certainty we have that these impacts are occurring and are attributable to climate change. I would give the caveat that just because a circle isn't dark doesn't mean that the impacts aren't happening. It probably means that we don't have very much data. And we even see here, for example, under mental health impacts, that it was not assessed, meaning we don't have data to even know what's going on there. So climate change and health is an emerging field. We are getting new information every day. And so what we can see here, I'm sorry this is so small, but that we're seeing impacts globally on water security, on agricultural production, animal, livestock, and fishery yields, infectious diseases, heat, malnutrition, and of course on our cities and settlements, as evidenced by the unprecedented flooding which happened in Libya just a couple of days ago. Oops, there we are in North America. The second main finding I want to draw your attention to is that climate change is worsening health inequities. So we know that everybody has their health impacted by climate change, but that those who are socially or economically marginalized are feeling the impacts first, and they are feeling them worst. The third finding is that the severity of climate-related health risks is highly dependent on how well health systems can protect people. And so I read this and I see this as an opportunity. So all these impacts which we're going to talk about today, these are not inevitabilities. These are opportunities. And when I say, well, what is the health system? I mean, we are the health system, right? We are the health system. So we are the people who can take this information and translate it into practice. But we're stuck in this caveat, because if the global healthcare sector were a country, it would be the 5th largest emitter of greenhouse gases on the planet. Ooh. So we do an incredible amount of good in the communities we serve, and we have this really large environmental and carbon footprint, right? So we're stuck in a bit of a paradox, right? We took oaths to do no harm, and yet, the externalities related to our activities are causing a lot of harm. But the reality is they don't have to. And that there's many health systems around the world who have committed to carbon neutrality and are making massive strides in order to prevent externalities related to their activities. So again, we have problems, we have solutions, right? So I'm going to transition now and talk a little bit about climate change and women's health. I'm an ER doctor. I'm not a climate scientist. I'm not a gender expert. I'm not an OB-GYN. I'm an ER doctor. Why am I here talking about climate change and women's health? So this is me on the border of Syria in 2018. And Syria experienced one of the largest droughts in the early 2000s that killed 80% of livestock and drove millions of refugees into already crowded cities where they've collided with people from different religious backgrounds. I'm not standing here saying that climate change caused this. Climate change had a huge role in the drought. There were a lot of factors that contributed, but this huge drought was a driving force in this migration and in this overpopulation and resource scarcity issue that was happening in many of the cities in Syria before the outbreak of violence. So there I am in this refugee camp. We went there with 20 physicians. 2 of us were women. We had no OB-GYNs, and we got to a refugee camp where 80% of the patients we were going to see were women and children. They're like, well, you're a woman. You see the women, right? So there I was in my tent, taking care of women who were coming in for all these complaints, right? Prenatal care, treatment of sexually transmitted infections, management of intrauterine fetal demise, requests for termination of pregnancy, help with fertility, dysfunctional uterine, I mean, it runs the gamut, right? I was so lucky that these 3 nursing students who had been displaced during the conflict came over early on and said, do you need help? I was like, yeah, please help me. They were translators. And by the time, after 3 months, they had basically taken over my job, which I feel so grateful for because care continues to get provided. So 80% of refugees worldwide are women, which is an incredible number, right? And currently there are over 80 million refugees. So my little clinic in this tiny little tent in the desert on the border of Syria is a microcosm of a massive issue which is happening globally, right? So let's take a look here at new displacements, new forced migrants in the year 2020. So what we see is that there were a total of about 40 million new displacements. Over here, we see those displaced due to conflict and violence. So that was about 10 million. What about the rest? Disasters, weather-related disasters. We could call these climate-related disasters, droughts, extreme temperatures, landslides due to heavy precipitation, wildfires, floods, storms, hurricanes. These are climate-driven disasters that are the major driver of forced migration happening globally today. So this is what brought me to climate change and women's health, because this is really a crisis for women in so many ways. So in 2016, the American College of Obstetrics and Gynecologists formally recognized that climate change is an urgent concern for women's health, stating that it threatens to widen existing gender-based health disparities and put women at elevated risk of disease, malnutrition, sexual violence, poor mental health, lack of reproductive control, negative obstetric outcomes, and death. They additionally highlight the impact of climate change on future generations, with the rate of low birth weight infants and birth complications increasing in regions impacted by the effects of climate change. Additionally, the World Health Organization and the UN have recognized that climate change threatens to widen gender gaps in terms of physical and mental well-being, which in turn threatens to undermine the achievement of sustainable development goals. So climate change changes everything, right? But how do we get from greenhouse gas emissions to the impacts that ACOG is talking about here? And so this work, these complex diagrams that we think about, we need to understand, right? Because if we can't understand how we get from elevated greenhouse gas emissions to ultimate health impacts, we can't manage it, we can't intervene. So we need to understand what happens here on many different levels. And so this is a lot of the work that I do around my research and what I think a lot of an emerging group of colleagues are doing to try to be able to understand this, to come up with effective clinical and policy level interventions to hopefully start buffering communities from these types of impacts. So this is a slightly different diagram, kind of looking at a similar thing in a slightly more simplified form, where we have climate impacts resulting in exposures, resulting in health outcomes. But what you'll see here is that on the flanks of this central diagram, so many things impact ultimate health outcomes. For example, land use change, geography, your age, your gender, your race, your ethnicity, your socioeconomic status. And so it gets complicated really quickly. If we took any individual one of us in this room, we would all have a very different profile in terms of our vulnerabilities to climate change. Another way of thinking about this is looking that each individual or each community has different exposures, different sensitivities, and a different ability to adapt to what the stresses are related to their health. So I want to give a few examples of this. And the first I want to talk about is the impact of extreme weather events on women's health. So this is a graph looking at the increases in disasters we've been seeing lately. So it's not your imagination. It's not there's more media coverage. We are seeing more and more climate-related disasters. So the blue is flooding, the kind of teal color is extreme weather, the red is drought, the darker red is extreme temperatures. We do see earthquakes, landslides. We're seeing more wildfires, right? So we are seeing more and more disasters. And we know that disasters affect everybody, but that in general, women are more likely to die during hurricanes and flooding events. So for example, there was a recent review of census information across 140 countries and found that basically women are more likely to be killed than men are. Just some examples. So in 1991, when cyclones in Bangladesh killed 140,000 people, 90% were women. I mean, it's shocking. And when Cyclone Nargis hit Myanmar in 2008, 65% of the 130,000 deaths were among women, right? We also know that female survivors suffer disproportionate decreases in life expectancy. So if you could sort of do a case control study of a man and a woman, you put them through the same disaster, women actually live less years of life. Something happens, our telomeres shorten, whatever it is, our life expectancy is decreased. There's also been a lot of work trying to understand what's happens to our pregnant population. So this is a study looking at the aftermath of Hurricane Harvey, where they found that women who delivered within 40 weeks of the hurricane suffered 27% increase in maternal morbidity and neonates a 50% increase in neonatal complications, and that these impacts were more severe among women of low socioeconomic status. Similar results were found after Hurricane Katrina, and this is in one of the most highly developed countries in the world, right? And so you couldn't extrapolate what would happen in a place where we have much more limited resources. In this study, researchers also looked for and found that birth complications were highly correlated with the degree of exposure and PTSD among women who had experienced the hurricane. And so there's also the mental health component, which is going into determining these ultimate birth outcomes. We also know that in the months following disasters that women suffer from decreased fertility, as well as deal with repercussions of loss of access to providers, to family planning, and to prenatal care. We also know that in addition to suffering higher mortality, women and girls are at high risk of physical, sexual, and intimate partner violence in the aftermath of disasters. And this is especially true among those belonging to marginalized sectors of society. So not surprisingly, women are at higher risk of mood disorders. It's not just that we're hormonal, right? We suffer greater rates of trauma. And simultaneously, we know women are often suffering worse economic loss and are excluded from the post-disaster workforce, either because of their skill sets or not, those in construction or remediation, or that they're home taking care of children and elderly because schools are closed, facilities are closed, and they end up taking on way more roles outside of their own professions. So I want to walk through an example of Hurricane Maria in Puerto Rico. So I was there about a month after the hurricane hit. This was in 2017. It was a Category 5 hurricane, which impacted essentially the entire island and resulted in extensive damage. Roughly 95% of the hospitals and health systems completely lost power, just to put that in perspective. So what happened to women's health? Well, in the aftermath of the hurricane, the 3 hotlines that were normally available to report domestic violence incidents went dead with the collapse of the island's telecommunications system. Even weeks after the hurricane, the 911 call center and the line to the Center for Assistance to Rape Victims was not restored. Weeks later, you could not call 911. I mean, this is in America, right? So second, we know that key systems designed to prevent and respond to gender-based violence collapsed. Police officers, including those who were assigned to the Special Unit for Domestic Violence, were detailed to other tasks, such as directing traffic. Judicial tribunals who were responsible for handling cases of violence against women were closed. There were only 4 shelters on the island for female victims. And so there was basically this entire collapse of legal and social infrastructure in the wake of a massive disaster where we have really good data to suspect that we know women are going to be highly vulnerable after this. And so I think we can do better than this. And we need to do better than this, right? Because we have good information now. And so we don't need to sort of leave this up to chance to see what's going to happen. As health professionals, as clinical health professionals, we have many levers to address this. You know, we need policy change, we need sweeping change, but as individuals, we can have action. For example, in clinical encounters, we can screen for mental health issues such as depression, such as PTSD and home safety. I mean, this has become more routine, but, you know, especially in the aftermath of disasters, we need to double down on that. We can be sure that our pregnant patients have contingency plans for delivery and management. Using our roles as health system leaders, we can advocate for gender-aware emergency planning. That includes health messaging, and we can advocate for economic recovery plans that take women's needs into account. So I just kind of pointed these out here. ACOG has come up with several different recommendations, including working with public health to identify facilities where women can receive care during disasters, and including that we need to involve OB-GYNs in the initial responses to disasters. You know, when you're going into a humanitarian aid camp, you need to bring about 20 OB-GYNs and then probably about 20 pediatricians. You know, we need to be thinking about this because we know what can happen. So I want to move on and talk a little bit about extreme heat. It was brought up earlier. You can't have missed the headlines, you know, this summer. And Chicago was actually in 1994. I'm not sure if anybody was here then, but there was a massive heat wave in Chicago, which really raised the profile of extreme heat as this silent killer. And through that event led to, unfortunately, but it did lead to a lot of understanding of the disproportionate impacts on racial minorities and on certain vulnerable populations in the city. So what's going on here? You know, over the past 150 years, you know, since the Industrial Revolution, we've seen a roughly 1.2 degree shift in average temperatures globally. And you think about that, it doesn't sound like that much. Like, what's the big deal? The big deal is that the curve is shifting to the left, but it's also flattening. So the variance is getting larger, the tails are growing longer. So we're seeing more of these extreme events, which is what we worry about when it comes to health impacts of extreme heat. So we know that women, and especially pregnant women, are highly vulnerable to this. There's physiologic reasons, but there's also many cultural and social reasons why. So evidence to date suggests that heat exposure is increasing the risk of preterm births, of low birth weight, and stillbirths. We know that exposure to heat at crucial developmental periods is associated with cognitive birth defects. And a lot of this literature has come out in the past 5 years. So this is an area where we don't totally understand why this is happening. We think it might have to do with activation of immunologic pathways related to placental health and blood flow to the placenta. But frankly, we don't actually totally know. And I'm involved in a study right now where we're enrolling a cohort of pregnant women in Pakistan to try to understand more about this. But so you have some awareness, we see epidemiologic trends, but we actually aren't really clear on what's happening physiologically. We need more information. So this is some interesting data which came out of Northern California. And here we're looking at the results of preterm deliveries related to temperature. And this is only a 10-degree Fahrenheit rise in temperature. And what we're seeing is the impacts are varying by race or ethnicity. Not necessarily because the physiology is different between these women, but because their risk profile is very different. So we look at Black women, their risk is 15% change, right? And then we look at white women, Hispanic women, Asian women, right? So it's varying by race, and that's because of structural racism and issues that happen in our cities related to environmental exposures. We're also looking here at an age breakdown of who's being most affected by this. And it's the really young mothers, right? Who maybe don't have the social support, don't have the economic finances to protect themselves. You can sort of make up a lot of narratives of what's going on here, but it's young mothers who are struggling the most here. So I want to draw your attention to the fact that, heat affects pregnancy, but heat also affects all women, no matter where you are. Was anyone in the Pacific Northwest during the heat wave in 2021? Did you? Okay. So this was a historically unprecedented heat wave. We had surface temperatures that were roughly 20 degrees Celsius above normal. No one in the Pacific Northwest has air conditioning, right? There was relatively little advanced warning, and there were acute on chronic capacity constraints. So this is an area where there's a lot of people moving there. It was COVID, right? So, hospitals were already maxed out, and then there was this heat wave. There was a 100-fold increase in heat-related ED visits, right? As an ER doctor, I sort of panic. That keeps me up at night. And so when we look at what happened mortality wise, we know that hundreds of people died in the surrounding areas. But what was found was that community deaths were higher in neighborhoods with material and social deprivation and lower levels of green space, that mental health and substance use disorders were significant risk factors, and that the highest risk was among females aged 65 to 85 for different reasons. But knowing this, as a clinician, as a nurse, as a PA, as a physician, as a pharmacist, as anyone who represents health, talking to patients, we know who's vulnerable, right? And we can give counseling to help prevent these types of events from happening. There's also some emerging research looking at the impacts of heat on breast cancer. Again, mechanisms somewhat unknown, but this was an occupational study looking at women who work in kitchens, work in laundry facilities, in areas where they're exposed to sort of chronic indoor heat, and found that they are actually at a much higher risk of having estrogen receptor positive breast cancer than are women who are not exposed to heat. We don't have epidemiologic studies to play out sort of how this works in ambient conditions. This is more of a controlled setting because where they've been working and for how long, but things we need to investigate more, right? So urgent research questions. By what mechanisms does heat exposure lead to poor birth outcomes? We don't know. What are the long-term impacts on children affected by heat during their gestation? We don't know. How does heat play a role in mediating breast cancer, right? So these are, I'd say, urgent research questions that we need to be addressing. Ideally, very quickly. And again, we have opportunities to protect our patients' health, both within clinical encounters as well as at institutional and public health levels. And I know that some programs and some health facilities around the country are actually now incorporating heat awareness as part of preventative guidance during prenatal visits, right? Prenatal time is such a great time. They find that women are more open to receiving information than almost at any other time during their life when they are pregnant, usually for the first time, but sometimes later. But this is the time when you could actually have people listen, right? And women really want to hear this, and they want to know what they can do about it. So this is, I think, another really interesting study. So Ahmedabad, India, very, very hot place. And what they were finding was that they were having really poor neonatal outcomes. And some of the researchers and some of the OB-GYNs decided to look into this. So the delivery floor was located on the 4th floor of an air-conditioned building. And I hate to say it, but the administrative unit was on the 1st floor and had air conditioning. Who planned to add that out, right? So what did they do? They put the delivery unit on the 1st floor with the air conditioning. They put the administrators upstairs and gave them fans, and they decreased these poor neonatal health outcomes literally overnight, right? It didn't cost any money. It upset a lot of administrators. I don't know, sorry, but we had better birth outcomes because of it, right? So a lot of times the solutions are not high-tech solutions. It's like we need to reorganize what we're doing, and we need to focus on this because we don't need to have birth outcomes that are this bad, right? So thinking about, how can you apply that lesson in your own practice or in your own facilities? So perhaps something we hear a little bit less about in the media, but I think is equally important, is the impact of climate change on infectious diseases. So we know that climate change is altering ecologic conditions such as humidity and temperature, which are influencing the distribution and the prevalence of vectors which carry, human diseases. The relationship is complicated, right? Now there's a lot of factors which mediate, whether or not there's a mosquito sitting there that's got dengue and whether it's going to give it to you or not. But in general, we have vectors in places that we never did before. And that's what's important here. So women are at risk of vector-borne diseases. And it's interesting because if you sort of think of traditional roles of women, we found they're often spend more time near standing water, right? Tend to be more in charge of the domestic court. And they, in places where there isn't potable water, they are the ones responsible for collecting water, right? And sometimes we would think, well, maybe there's actually more risk of vector-borne diseases after heavy rains and flooding. It turns out to be the opposite. We see more vector-borne diseases when there's drought because people are storing water close to their house. When pregnant women are very high risk of this. So this is kind of crazy to think about, but pregnant women have higher CO2 production, which is actually a chemoattractant for mosquitoes. That's how they locate you. Terrifying. They also have increased peripheral blood flow. And so mosquitoes use CO2 and heat to locate you. And so they're more likely to locate pregnant women. So they're at higher risk of actually getting bitten. Once infected, because of immunologic changes during pregnancy, they manifest higher rates of viremia and parasitemia. So for example, we know with malaria, the risk of severe malaria is 3 times higher in that of pregnant women than those women who are not pregnant. They get much higher parasitemic loads and their immune systems are functioning differently to protect them. Dengue is another virus which is expanding rapidly under changing climatic conditions. We know dengue during pregnancy increases the risk of cesarean delivery, of preeclampsia, and there's also a risk of vertical transmission. And of course, we're all very knowledgeable now about Zika, which is also transmitted by the Aedes aegypti mosquito. So this is data from the Lancet countdown. And what we're looking at here is the change in vectoral capacity, which is a way of saying how likely an infected mosquito is to infect a person. And this is going up for Aedes aegypti and Aedes alopecia. And those 2 mosquitoes transmit dengue as well as Zika and chikungunya. And so we're seeing dengue expand to places we've never seen it before. There's been some really good research looking at the emergence, or rather the intensifying of dengue in sub-Saharan Africa. Usually, when someone comes to a hospital with a fever in Africa, it's malaria, right? And oftentimes in rural areas, people don't even test because you don't have a point of care test. You just treat them with an artemisian or something like that. But malaria mosquitoes actually don't really like the heat. So we're seeing malaria go down. Aedes aegypti and Aedes alopecia love the heat. And so we're seeing an explosion of dengue in places in the world where it was never really the leading problem. And so what do we have to do? We need to increase our surveillance, right? We need to sort of rethink. We can't base our current practice on assumptions from the past of what was present in one place versus another place. Although we are seeing malaria increase, particularly in the highland areas. So because it's cooler higher up, traditionally places that were high elevation didn't have malaria, but now suddenly you have these immunonaive communities living at high altitude who are now getting malaria for the first time. They have to keep kind of going up to get out and away. Locally here, we're seeing changes in the distribution of Lyme disease. And so we look here at 1996 to 2019. I'm sorry they don't show Canada in this because Canada is experiencing massive increases in Lyme disease as well. But just look what's happened over the past, that's only 20 years. Our winters aren't as cold anymore, so the ticks aren't dying off. And this is a similar issue with what's happening with wildfires, whereby because our winters aren't cold, we get escalation in these populations of bark beetles, which kill the trees and lead to a lot of downed trees. So not having cold winters is a big problem when it comes to this. And so this is important for us as health professionals, as public health professionals, as clinicians, right? If you're sitting somewhere out in Nebraska, you're a family doc, not to pick on family docs, but you've been practicing for 40 years. Someone comes in with a weird rash and some joint pains. You're not thinking Lyme. You're not. You never see Lyme, right? It's like, but now we have to start training our existing health workforce to start thinking about Lyme disease. This could be happening, right? Okay, what can we do about this? Well, it turns out that women are at risk of this, but they are also the key to so many solutions. So this was an intervention whereby some colleagues I know, Casey Ernst and Mary Hayden, were working in a community that had really high rates of dengue. And they basically went in and they trained women on what are vector habitats. What can you do to protect yourself? Okay, we need to dump out the standing water. You need to cover your water being held. Here's some, insecticide. And literally just by training women, spending one day training women, they cut the rate of dengue transmission in that community by 50% overnight because they educated women about it, I have to say, right? And they told each other, and it went through the gossip chain, and the whole community started doing this, right? It took a one-day education event, but it takes a lot to put that together. There's barriers, but it's not incredibly high-tech interventions. It's not super expensive interventions. It's literally education of women, which gets us to these places. We can't talk about climate change without talking about air pollution because, the issue here is one and the same, which is the burning of fossil fuels, right? Which produces CO2. It also produces PM 2.5, so very small particulate matter, which gets deep into our lungs and can affect us in many ways. We touched on wildfires. I know Chicago experienced a lot of this. This was an interesting study that is looking at the cumulative forest acres burned from wildfires basically over the past 40 years. And what you see is that the yellow shows the extent to which wildfires would have burned without climate change and that with climate change. So climate change is driving wildfires. It's not the only cause of wildfires. Wildfires are a natural process. But again, we have more bark beetles and pests. We have higher temperatures. We have drought, and those things are also contributing. Now, what we know about wildfire smoke exposure is that it can actually be 10 times more dangerous than simple tailpipe emissions. And so why is that? I don't know if you remember the images of Paradise, California burning, right? And the fires swept through and you saw like backyard plastic swimming pools burning and people's garages burning. And you think about all these things that are getting airborne that were never meant to be burned. And so for reasons like that, exposure to wildfire smoke is actually way more dangerous and frankly, almost more difficult to control than tailpipe emissions, and which are also hard to control. But we've been dumping tens of billions of dollars into wildfire mitigation, and we still can't stop wildfires, right? That's one of the things we have to deal with. Women deal with ambient air pollution, which constitutes, tailpipe emissions, wildfires. They're also preferentially in many parts of the world exposed to indoor air pollution, right? So they're in charge of cooking, cleaning, and oftentimes are still burning biomass in order to cook their food, right? I had a woman come into my emergency room in northern Colorado, where we actually have a lot of people who are coming from North Africa. It was part of this UN refugee program from the 80s. And this woman was in her 50s, never smoked a cigarette a day in her life. And we did a chest x-ray, and her degree of emphysema was that of somebody who was like a 2-pack per day smoker. And it was because of, several decades growing up as a small child, all the way through her childhood, cooking over open fires, right? So this is a major issue that, needs to be addressed along with it. But thinking about women's health and thinking about the concomitant risks, right? It's not physiologic vulnerabilities, it's kind of cultural and social vulnerabilities, right? So we're getting some data. Well, this is a complicated slide for those interested in biochemistry and pathophysiology, looking at why PM 2.5 is so disturbing to our health. We breathe it in our lungs where it causes inflammation. But the really small stuff, the PM 2.5, that's why we track it. It's particulate matter less than 2.5 micrometers, can cross over our alveolar capillary membranes, basically get into every organ system in our body, causing endothelial dysfunction, causing reactive oxygen species to be generated. And so you sort of can imagine that. So we know air pollution is linked with neurodegenerative diseases, neurocognitive issues, with depression, anxiety, Alzheimer's. We know it affects cardiovascular disease, diabetes, kidney disease, et cetera, et cetera. We have some emerging good studies looking at the impacts of ambient air pollution on pregnancy. And as we know, it affects every organ. So we know that exposure to particulate matter and ozone is significantly associated with a high risk for preterm birth and low birth weight, right? This was looking at birth weights following the 2003 Southern California wildfires. They found small but significant impacts on birth weight among maternal cohort, and that the impacts were actually happening in all trimesters. There were risks going across them. But this was cool. So in this area of California, they recently retired coal and oil plants and basically found an association with reduced preterm births. So there was a decrease of 27% in preterm births once they closed these 8 power plants. And there was actually a stronger association among non-Hispanic Blacks and Asians who tend to live in these areas, which are really environmental justice communities, right? And so the solutions immediately benefit health, right? And I think that's, just something we can think about. And a big issue that comes up when we think about decarbonization is that we get the long-term benefits of not accelerating climate change, but we see short-term gains in health literally overnight. And so that's really exciting. We also know that cutting emissions actually pays for itself in health savings, roughly on a 10-to-1 type of ratio. If you think about it, there's a great study that was published in 2011 looking at the economic impacts of, I think they basically looked at 10 climate-related events: wildfires, flooding, hurricanes. Each one leads to several $1 billion in healthcare costs. These are preterm deliveries, asthma exacerbations, heart attacks, all these issues that drive people into health systems. And if we could avoid those, well, that's a return on investment, right? It's money that will never have to be spent. But that's kind of a difficult sell to people. You're like, well, you're going to spend this money, but if you do this, you're not going to have to spend that money. They're like, I don't know if I trust you. Okay. So we've talked about vector-borne disease. We've talked about heat. We've talked about air pollution. We have these sort of catastrophic ideas of climate change, but there's also the more insidious impacts that we're seeing, right? Some more subtle things that we are observing, but we don't see unless we kind of look more closely at it. So climate change has major impacts on the hydrologic cycle. It leads to some areas becoming more arid, while others are becoming much more likely to have extreme precipitation events. I remember learning about that. I was like, extreme precipitation, like it's just raining hard. Like, what's the big deal? And I've completely changed my mind about this. Because extreme precipitation in areas where the infrastructure is not up to it, we get what happened in Libya this week, right? Like heavy precipitation leading to flooding has become a leading issue of damages to infrastructure, settlements, and ultimately health, right? And globally, we know that there's an uneven distribution of fresh water with the highest scarcity in the most populated areas. This is where we're anticipating to see water stress in 2040. Large parts of the US West are already experiencing water scarcity. And we continue to water our lawns because we don't have strong enough policy to do anything otherwise. But we're affected too. And, there's many issues related to this. Everyone's fighting over the Colorado River right now. But the people who really actually probably should have access to it are the indigenous communities who live there, who have been completely excluded from the conversations around whose right it is to have access to water. So that's a related issue. So this is looking at where we're expecting more extreme precipitation. Sorry, I shouldn't say water stress in 2040. This is looking at where we're expecting extreme precipitation to be occurring. So in our country, kind of looking Pacific Northwest, it's going to be a lot wetter, if it even could be any wetter there. And the Northeast, right? Our temperate rainforests are going to be experiencing a lot more. It also makes rainfall more unpredictable, right? So in India every year, you anticipate that the monsoon is going to come. And it's almost like festivals are structured around the coming of the monsoon, but now the monsoon is not coming, or it's coming early, or it's way too heavy than it ever been. It actually wipes out all the crops instead of giving them the water that they need. And so there's a lot of modeling going on around now to try to predict, what's going to happen with the monsoon. It's almost like become sort of a spiritual practice in and of its own to try to predict this stuff. So water scarcity and water is so closely related to women's health. And I think we kind of know that. Women often have the household role of providing water to a family. And so water scarcity equates to more time spent harvesting water. So if you normally have to walk a mile to get water, but then that water source is dried up, now you're going to walk 4 miles to get water. It's going to take you 4 times as long. That's time that you could have spent, working on your small business, spending time with your children, educating, like all the other things you could be doing. You are now going to harvest water, right? We also know that the risk of adverse pregnancy outcomes is worse when women do not have access to sanitation. So drinking water and sanitation go closely hand in hand. And we have to be thinking about both of them because when there's poor sanitation, that is a direct predictor of whether or not there will be healthy pregnancies in that area. So food, water, the staples of a civilization and a society. We know that food insecurity is becoming a rising issue, primarily related to drought and unpredictable rainfall. So currently, roughly 80% of agricultural produce globally is rain-fed. I don't think I realized that because in the US, we have massive irrigation, we pipe water everywhere. But in most parts of the world, we count on rainfall to come. And so unpredictable rainfall leads to not having enough nutrition, right? And so this is an issue which affects women in many ways. So in low-income countries, women actually produce between 60 to 80% of all food. Women are on the front lines of food provision. And oftentimes women are also not owners of land, right? Because of cultural norms, because of policy norms, they don't have land titles. Of the 1% of female farmers who actually own land, less than 2% have crop insurance because they're also similarly excluded from the institutional structures which could provide insurance, right? I was talking to an awesome student today who was working on microfinance around providing small grants to women to be able to start initiatives. Hi. So, I mean, just like thinking about the links of this and thinking about the solutions, I mean, that's a really inspiring one. There's also a link between heat and labor productivity. So in 2021 alone, over 400 billion hours of potential labor were lost due to extreme heat. And something like 86% of those were in countries that have a low human development index. I'm just going to say that again, 400 billion hours of lost work, 86% in places with a low human development index. So these are among places where if you can't farm, because it's so hot, you actually can't get food, right? So this is really a crisis, and we're seeing more and more of it. I spent several years working in Guatemala studying chronic kidney disease of unknown origin, which is this epidemic that's happening in Central America, northern India, and likely we think in Africa, related to heat stress nephropathy, which causes an accelerated onset of end-stage renal disease in primarily young men between the ages of 20 and 40, related to heat exposure, right? So the loss of productivity is often the first sign of health harms from heat, is what we concluded from our studies. So decreased labor productivity, you can't help it, you slow down because your body is starting to get sick, right? So this is telling me that we have, millions of workers out there who are getting sick or potentially butting up against that place where they're getting sick because of heat. So again, facing these challenges with courage, with innovation, with solutions, right? This is a quote from the IPCC chair. We have the tools and know-how required to limit warming. We do not need another technologic breakthrough. We have options in all sectors to at least have emissions by 2030. This is great news. We're not waiting for scientists to come up with another solution. I mean, we have solutions. We need to deploy them, right? This is a great quote from Mary Robinson. She said, if we took away barriers to women's leadership, we would solve the climate change problem a lot faster. Okay, so who are women? What are women? Women are educators, we're caregivers, leaders, innovators, agents of change in communities. Women often prioritize family and community in decision-making. And these are studies, big studies that happen. And I'm not trying to make the men feel bad in this room, really. Research shows that women tend to show greater concern for the environment and issues of inequity. Including women in climate decision-making tends to lead to more effective, equitable, and sustainable solutions. Super interesting, right? This is a cool study. So what we're looking at here, let's look at the red graph on the right first. So we're looking at gender inequality and climate vulnerability. So as gender inequality goes up, that region's vulnerability to climate change goes up. On the converse, climate action, when there's less gender inequality, there's more climate action in a community or in a region, right? So, I mean, you can show graphs, you can do data, like, you know, we need to empower women with solutions to change what's happening here, because they are agents of change, and we have enough science to understand this, right? So how does that relate back to one of the things we started with, which is that we are the health sector, right? We are health professionals. We're private citizens, we're institutional leaders. We're trusted community voices. When they do surveys of like, who do you trust more? You know, your teacher, priest, you know, a legislator, a nurse, or a doctor. Who's first every year? Nurses. Who's second? Doctors. Pharmacists are up there though, you know, but okay, so let's train the nurses, right? We're trusted community voices. We're researchers. We're clinicians. We wear so many hats, right? And in all these different roles we have, you know, we can find ways to start tackling these different issues. And it's not going to be the same for all of us. If I had a magic prescription pad, you know, I would say we need to adapt our clinical practice and work to increase the resilience of the healthcare systems where we are, right? Local action is huge here. Here's just some links to some resources, you know, when you're talking to patients, you know, there's great handouts about how to beat the heat, about climate change and pregnancy, right? We can incorporate these tomorrow, thinking about risks to our patients, right? Again, going back to this really uncomfortable statistic that our actual day-to-day practices are impacting the crisis that we're in. The climate care, the healthcare climate pledge. This is a pledge which now more than 70 healthcare institutions representing the interests of 14,000 hospitals have joined. And this is a pledge to decarbonize hospitals and health systems by the year 2050. And this is really cool. It's a voluntary pledge because, you know, so it has no teeth behind it. You get punished if you don't do it, but it starts to stimulate action. And it starts to have the hospitals have those conversations, because the reality is that when you enact simple measures such as looking at, you know, switching to LED bulbs, having light sensors that go on in rooms, like simple stuff, not massive investments, looking at waste segregation, single-use device reprocessing, things like this, which we have good information on, hospitals save a ton of money, right? I don't know a single hospital CEO who doesn't want to save money, right? We're in a crisis right now. This is a way to save money, right? It's going to take a little upfront investment in human resources to make things happen, but this actually will save us money, right? Okay. Other prescription I'd write is that we continue to educate ourselves, our students, and our patients, learning every day. Like I said, I'm not a climate scientist. I try, you know, but we need to continue to educate each other, to talk to colleagues even outside of the health profession, right? Because a lot of times solutions need to be interdisciplinary. And I think as health professionals, you know, next time you're at a dinner conversation, bring something up, right? See how this goes. Educate yourselves and each other. We had a really great lunch session today with students, and they just ended up talking and telling each other stories about the things that they knew. And it was amazing how much everybody knew in the room, right? We can crowdsource a lot. Okay. I think this is an interesting diagram, and this is what motivates the current work that I do. You can barely see it. It's great. You can't give a talk without putting a graph up that nobody can read. It's the rule of academic talks. Okay. So what this is saying is that this was a survey. 4,000, these were nurses and doctors from around the world. In terms of how concerned are you about the health impacts of climate change on your patients, right? And the red is basically the key saying, like, I am worried this will become more frequent or severe the next 5 to 10 years. And the blue bars are basically saying this actually is already impacting my patients, right? We're looking at air pollution, mental health, physical harm, all these things. So health professionals, we are actually pretty aware that this is happening. This kind of was surprising to me because nobody ever talks about it, but everyone's thinking about it. Okay, What this study uncovered, though, is that, and then they asked that question, which was great. Well, what is the barrier to action? And again, health professionals said, we need more education. I think it's a little bit of a victim of our culture, whereby, we spent too much time on medical rounds getting humiliated for not knowing the right answer, that we don't want to open our mouths unless we're really, really sure we know what we're talking about. Because we're all really concerned about it, but we all want more education. Okay, so we need more education. That's fine. I direct the Global Consortium on Climate and Health Education. And so our mission is to ensure that 100% of health professionals have the knowledge and skills to recognize, respond to, and prevent climate-related health impacts. There is a huge need for climate and health education. So right now we have over 350 health professional training institutions who have pledged at the level of the dean or the president of the school to train their students in climate and health, which is really exciting. And our numbers are growing, by the day, which is great. We also collaborate with many different partners. I don't have them up here, but the AAMC just joined us. So did ADEA, which is the American Dental Education Association, the American College of Veterinary, AAVMC. The veterinary medical colleges have joined as well. And we work around the globe with different partners, and we create resources for educators. We also create broad-based free CME granting courses to train existing health professionals. It's funny because actually students might know more about this than faculty. And so faculty obviously are like, well, I can't teach this. I never learned this. Well, we're going to train the faculty then, right? We're going to give them that courage. We're going to give them that knowledge that they need to be able to work. This slide got a little funky, but this is a report that the AAMC came out with, which is really exciting. They are moving on this, which is great to see. So they did a research analysis looking at climate action in medical school. This was published about 6 months ago, and they concluded that over the past 3 years, the percentage of medical schools with required curriculum on the health impacts of climate change has doubled. 5 in 10 schools have required climate change curriculum, which is really exciting. This is a rapid acceleration, and I think is a really positive sign, especially with the AAMC getting behind it. So where do you get involved, right? How do you find your sweet spot? And so this is advice from Dr. Ayanna Johnson, how to find joy in climate action, because it's a hard place to work. So she says there's a sweet spot, right? What brings you joy, right? What gets you up in the morning? Neglecting your joy will lead to burnout. Okay, so what brings you joy? What is the work that needs to be done? And I think us as health professionals, we are a roll up your sleeves type of people, right? We don't sit around, we roll up our sleeves, and we can recognize work that needs to get done. And then we think about what we're good at. Are we great educators? Are we awesome researchers? Are we the most effective administrator that's ever walked the halls? What are we good at? And somewhere in the middle of there is what you should do. Okay, so that's my part. That's kind of a little bit of my parting advice here. Here's my email address. Feel free to contact me, and I'll hook you up with resources and anything else you need. Sorry, I ran way over. And that's it. Okay, we probably don't have time for Q&A. Okay, thanks.
We are for now going to move our audience Q&A to after our panel. So we are going to be taking a 5-minute break, and we will return for our panel titled, Is Climate Change a Gender Issue? All right, welcome back to the Rosalind Franklin University of Medicine and Science 8th Annual Women in Science and Healthcare Symposium, Mother Earth Under the Microscope, Climate Change and Women's Health. Thank you again to Dr. Cecilia Sorensen for her outstanding keynote, Rethinking Women's Health in a Changing Climate. We will now move into our panel portion of the symposium, Is Climate Change a Gender Issue? Today's panel will be moderated by Dr. Regina De Leon Gomez. Dr. De Leon Gomez became a climate activist after learning the inconvenient truth at the 2017 Climate Reality Leadership Corps training. Leveraging her experiences as an obstetrician and gynecologist, she began grassroots work in her faith community, the League of Women's Voters, and the Society of OBGYN Hospitalists. Dr. De Leon Gomez helped to establish the Illinois Clinicians for Climate Action to encourage other healthcare professionals to use their voice to protect our environment and the health of the community. She welcomes anyone who wishes to join the climate advocacy effort. Together, we can realize a better future for ourselves and our children. Please help me welcome Dr. Regina De Leon Gomez.
So we're back, and I am proud to be faculty at Rosalind Franklin University and Chicago Medical School. I'm very excited to have our panelists with us today to moderate our conversation, continue the conversation. And the WISH committee is asking the vital question, is climate change a gender issue? So if you were here with us in the last hour, we got a lot of information on that, but we'd like to kind of delve deeper with our panelists. I'll just do some brief introductions of each of our panelists. In the third seat, we have Neha Basti, who is a third-year medical student at Chicago Medical School. Actually, I knew Neha when she was a first year, and it's really exciting to see you now in this role and in this capacity, so welcome. Neha's undergraduate work was in neuroscience and sociology, and Neha served in the AmeriCorps before starting medical school. As the founding co-director of the Chicago Medical School's chapter of the Planetary Health Report Card, alongside M3 classmate Allison Money, they led a team of 22 medical students in completing our inaugural report card for CMS. Todd Beer, to my right, is an associate professor of sociology at Lake Forest College. Professor Beer conducts research and teaches about the sociology of climate change, social movements, and cultural globalization. His research cites communities and organizations throughout Kenya and major protest events in Chicago, Washington, D.C., New York, and Paris. His current research examines the ways in which global cultural norms around environmental conservation, gender equality, and education as a formal pathway to development interact in a rural Maasai community in southern Kenya. Additionally, his research examines support for anti-capitalist policies among climate change protesters, support for global climate justice among U.S. protesters, and the opinions and actions of non-governmental organizations throughout Africa that are members of the Pan-African Climate Justice Alliance. Welcome. Jim Burgess leads all aspects of Medline sustainability efforts. He has 20 years of Medline experience and has led engineering, product development, and operations teams. Jim's main expertise has been in plastics, where he has led the implementation of many new capital projects. Throughout his career, he has been involved with sustainability as it relates to plastic in areas such as packaging, reduction in efficiency, weight reduction, recyclability, and alternative material development. Jim has a Bachelor of Science in Chemical Engineering from the University of Illinois at Urbana-Champaign. And thank you, Dr. Sorensen, for continuing to participate in our conversation. We're glad that you're all with us here today. So I know that our audience members would like to hear more about you from you. So maybe we could take 2 to 3 minutes. Maybe you can share a little bit more about yourself, maybe what inspired you and what sustains your work in this arena. And I'd like to start with Neha.
Sure. Hi, everyone. My name is Neha Basti. I'm a third-year medical student at CMS. Thanks to WISH for putting together this very amazing event, and it's nice to be back on campus and see so many familiar faces. My journey with climate advocacy started in middle school. My friends and I advocated for a recycling program in front of our middle school administrators, and we'd spend our lunch period with gloves on, sorting through the lunch trash to separate the trash from the recycling. So we were very popular. But that definition of climate advocacy stuck with me, even when it came to undergrad. In hindsight, I was really interested in individual level action, like plastic reduction and composting on an individual level. And then I shifted gears in the year before medical school and in the past 2 years of medical school, based on the fact that 1, climate change is a public health threat, and 2, we need very large scale level change for our planet to remain habitable. So the projects that I've been interested in medical school stem from the belief that my generation of future physicians and healthcare professionals, we really need training on this topic in order to care for our future patients. So I'm so grateful to the example of medical students who have come before me, who have exemplified what it means to still be a student and still show up for this work, and especially to faculty here at the university who have encouraged me to use my voice while still in the student capacity. So I hope in being here, other students who are listening who can feel like they have a voice in this space as well. So thank you.
Thank you so much. And Professor Beer?
I came to academia later than usual. And so I brought with me a diversity of experiences, from careers leading wilderness expeditions from California up to Alaska, to working as a photojournalist, including in Bosnia in the mid-90s, to mostly what drove me towards this issue was working in Mozambique and Kenya as a volunteer, collecting some research data, and then running service learning trips also in Tanzania and Nepal. I think everybody who's involved in this work is inspired by a rather common and fundamental kind of modern moral compass that says, oh, we need to be concerned about those who are in more precarity than we are, especially when we are part of the problem. That may take many different forms or different names, but I think that's kind of the fundamental thing that drives a lot of people. You asked one particular what sustains us as well. And it's in large part that empathy for others, right? Having been to a lot of places in the world that live dramatically different than we do. What sustains me is the collective action that is being made. So you can't do this alone. You'll become miserable quickly. And so looking around and seeing all that's being done by other people as well. And then just a basic fundamental appreciation of the beauty of so many places, not just human communities, but non-human species and places, from, mountain glaciers to a place like Venice and New Orleans that are both going to be gone, and what we'll lose from that culturally, in Pacific Island nations, things like that.
All right, so I'm Jim Burgess. I'm probably the only one here without initials or letters behind my name. So I haven't been involved in research or anything like that. I've been in industry for most of my career here. But personally, what's drawn me to this area is I'm a big proponent of health and personal health and achieving optimal health, and coming to terms at one point, I don't remember when it was, that not everybody has the opportunity to do that, especially those in our most under-resourced areas. It was something that really drew me to this this particular field here, and trying to ensure that those out there that haven't been able to do that get the opportunity at some point to do so. Secondly, professionally, I will say, right, I've been in plastics as I was introduced here my entire career. So personally, I've been probably somewhat part of the problem in developing plastic items that are more disposable, that can be more easily disposed of, more easily used, sometimes for the right reasons, but of course, sometimes not. So getting into this world and using that knowledge in order to turn it around and come up with some of the solutions that we need, I thought was extremely important, where I can make a personal impact here.
Thank you so much. Could we hand the mic over to Dr.
I think you know me by
Sorensen?
now. I've been talking a lot. I think it's sort of, what sustains me at this point is being in rooms like this, where I see light bulbs going off in people's eyes, resonating with what these issues are. That keeps me going. And the youth and students like you, Neha, who honestly are so passionate about this, are so driven, who aren't jaded about, the world, and you see possibility where many people see despair. And I think that keeps your energy and energy of so many students who I've had the privilege of working with, keeps me lit up about these issues. So thank you so much for all the work you're doing.
And I'm going to have you hold on to that microphone and ask one follow-up question. Obviously, you've been working in this arena for such a long time. And I'm sure you've had challenges. Have you had any revelations, any lessons any revelations or lessons that you've learned in your years of working?
Revelations. That's a good question. I think that it's been a slightly non-traditional course through medicine, right? And I've always found, though, that no matter where you go, there's people who understand this. And I put that data up, 90% of physicians are very highly concerned about this, and nobody talks about it. And I think that is sort of the revelation to me, is that we are all thinking about these issues, and yet when it finally comes to the forefront, we're able to talk about them. Oh my gosh, just in this room, I'm sure we could crowdsource hundreds of different solutions to what's happening. And that's where, I think that's my aha, that's my revelation, right? Revelation is that, we have solutions, at our fingertips. I was recently, I just came from the Dominican Republic, where I'm working with communities to build resilience centers, climate resilience centers. And we bring communities in and we say, well, what do you think you need? What would you like in this resilience center? And the ideas that come forward, people who don't necessarily have a formal education in sociology are putting forth these ideas of what social programs would support the community and empower women, empower youth, right? That's where I think the revelations come to me every day, is in talking to community members, talking to colleagues, and just seeing how much untapped potential there is to create change.
That's a really good point to go to Professor Beer. Just about the sociology. Could you share with us, in your work, how can we bring women to the table? How can we move on this issue?
Well, not necessarily my research, but larger sociological research all points to things that we saw in the presentation. Women are more concerned about this, largely because the way we socialize gender in our country, that the gender difference is amplified in wealthier countries. So there is more of a gender difference around climate concern in wealthier countries like the United States, where it's become more politicized. So yes, it's a gender issue, but you have to lay other things on top of that. Race, political ideology as well can be stronger predictors than gender necessarily. I think that you can use evidence to bring women to the table. So S&P 500 companies that have more women on their board are doing more about climate change. Legislative bodies that have a higher percentage of females elected to them are doing more about climate change around the world. And so men either get on board or get out of the way, because if we're going to do something about this. And so some of the research about the way that we socialize male identity, right, feeds them into seeking rewards and status through kind of traditional capital accumulation in a system that says, whoa, you're talking about changing the entire energy system of the way that we have succeeded right now. Now, in my mind, if everybody was smart about that, they would see, look at all of these new opportunities. There's going to be a shift in capital that we have not seen in 100 years over the next, hopefully 10, 20, 30 years. Research shows that white men in particular put up this shield because they try and protect their status, right? And they see adaptation to climate change as a threat to that status. So we need to make sure that men feel welcome, which is kind of a ridiculous thing to say, but apparently collectively we're very sensitive and concerned about our status. And so if we can make sure that they realize that as we mitigate climate change, there's still going to be a place for us, then maybe that can bring more people to the table.
maybe I need to be more fair. Okay, so in your research, and especially with the protests, are there any findings as far as like who's protesting and how effective are these protests, and does it matter, where these protests are occurring?
So participation in protests is a mixed bag. Some of the older research says that women were more concerned about environmental issues, but less likely to take public action, more likely to take private action. In every piece of survey data, so thousands of data points across very large climate protests, to be updated after this weekend in New York City on Sunday. Women were a slight majority, so it was more reflective of the population, 55 to 45 kind of ratios, with more women actually being at those events through random sampling procedures. Protests matter. I mean, if you look at historical change, they're not immediate, they're not alone, right? But if you look at other climate things going on right now, with lawsuits, mostly by young people, but not exclusively, before states, with having some success, most recently in Montana, so what's going to happen in New York, right? They're not going to get a seat with legislatures right away or whatever, but they're going to hit headlines everywhere, hopefully, with the number of people who will be there. And it's the first one since 2017, COVID, et cetera, added to that. But those bring attention to the public. There are also places where you can get motivated and excited and not feel alone, and make connections with other people.
Well, thank you so much. So I wanted to shift gears a little bit. I think we have a responsibility to kind of talk about healthcare and the impact of healthcare. And Dr. Sorensen did speak in the keynote about the impact that we have on the health of the patients that we're actually trying to serve. So I think this is perfect for Jim. One of Dr. Sorensen's slides said that, if we make sustainable choices, this pays for itself. I mean, can you kind of elaborate a little bit more on that, and why this is important, and how we can help leadership kind of accept this information and see the connection with the people that we are actually trying to serve?
Sure. So I guess backing up slightly to do some extra table setting, and Dr. Sorensen did a very good job at this. But the slide up there, when it came to if healthcare was its own industry, it'd be the number 5 emitter. To put that in a little bit different perspective, healthcare accounts for 4.5%, over 4.5% of total greenhouse gas emissions, the healthcare sector alone. So that's pretty significant, right? And there's good reasons for that. One of them being that healthcare facilities take over 2.5 times the amount of energy and resources to run versus a standard office building. The products that we use, a lot of them are really built around being disposable at this point for infection prevention reasons. So there's just been this huge buildup of why healthcare takes so much intense carbon in order to keep running, and because of that, it's going to be quite a large barrier to get past at some point. But when it comes to solutions and how we look at this issue of double materiality, or that magic spot where it's great for the healthcare system and it's also great for the planet as well. We just haven't uncovered enough of those, enough of those solutions there. So Dr. Sorensen talked about energy efficiency. She talked about, how that's going to really make our bottom lines or our operating expenses go down. There's things we can do within the products themselves, right? So point of use, instead of using a large tape roll or ordering a large tape roll, we can order smaller tape rolls. So we're only using what we need. Large surgical packs, right? Let's only put in there what we need. So we're not taking the extra XYZ that's in there. And it's not going back to stock, right? It's ending up in the landfill. And then on top of that, there's just not enough recycling programs today. So more effort needs to be put on doing so. And I know the OR is very crowded, right? And anytime we approach some sort of recycling or something extra to do in the OR, it's not easy to do, but there's definitely solutions that are embedded in there. So, and I'm going to hit on one other thing, and that's there's not enough to do to make an impact in just changing the LED lights or making our buildings more efficient. And I'm going to go to supply chain, and you're probably thinking, well, duh, Jim, you worked in supply chain. Of course, you're going to go there. But here's the stat, right? Over 70% of the emissions caused by the healthcare system are in supply chain and the products that we use. So we can do as much as we want to our buildings. We can do as much as we want to the fuel we're burning. We can air condition and change that over from the carbon intense power production we have right now to wind, but we still have all the products that we're buying in that supply chain that we need solutions for. And there's no silver bullet to that, right? We have barriers that are going to be the medical devices that we use, right? They have to perform a purpose, and the materials that we've chosen today certainly have been chosen for a reason. So we have to re-come up with those. We have to think how we're using those. We have to rethink how we're going to reprocess these devices potentially. So there's solutions that are out there, but that supply chain is really, to me, what it means to tackle sustainability within the healthcare world.
Thank you so much for that comment. If you could hand the microphone over to Neha. I wanted to give Neha an opportunity to talk a little bit about Planetary Health Report Card in case our audience members are not aware of the work that you and the 22 other students have done on that and kind of how it impacted you. Could you tell us a little bit?
Sure. So Planetary Health Report Card is an international initiative. It was created by medical students in 2019, and it's still run by students today. The team puts out a report card, like the name suggests, that looks at 5 components at a university. That's their support for student-led initiatives, community outreach, campus sustainability, research, and the curriculum, all related to planetary health. It does give out a grade, but anyone who's heard me talk about PHRC knows that I always say the grade is not the goal. I know we love to get perfect grades and hyperfixate on that aspect. But PHRC is a tool. It's a conversation starter that my classmates and I have been able to use to speak to faculty and administrators and brainstorm ways that we can work together to talk more about planetary health here at the university. I have to acknowledge Allison Money and the 22 other medical students who worked on this. This was not just me. And it was really meaningful to do our inaugural report here at CMS. In terms of how it impacted me, it was really special to find community amongst students who, I'm just so humbled by students who are able to bring their time and energy to this topic while also being medical students. That's not a small undertaking. So I'm really grateful for all the students that I've gotten to work with. On the flip side of things, we've had an overwhelmingly positive response from faculty and administrators who've encouraged us to present our findings at meetings, and shared personally why this topic means something to them. So that sense of community has made me feel like there's a potential for change, there's purpose, and people care. And it's only been 1 year, so I really feel like it's just the beginning, and I'm excited for what we can do next year as well.
Well, thank you so much, Neha. I did want to ask one kind of general question and see if any one of you would like to comment. A July 2023 New York Times headline was "Climate Disasters Daily. Welcome to the New Normal." What were your personal reactions to this headline? Is the new normal the same for everyone?
Sure, I'll bite. So, as we've looked over the last, let's call it 15 years at climate change, and we've heard reports about what it's going to mean and when we're going to see extreme events and things, they've typically been off at 2060, 2080, 2100, right? But we're seeing them today. So, and as we know, because we're in health right here, all of these events are certainly, and I can't add any more to what Dr. Sorensen put up there in the multiple different examples of our less resource population becoming more affected by this, right? So they're not going to be as resilient as or there's just going to be different levels of resiliency based on the resources that we have available. So, and I think that's what keeps me inspired to be in this particular area, is to make sure that we're continuing to make progress to equal that field, and ensure that everybody's going to be able to survive moving forward here.
I'm always like, I'm like, I study this a lot, so I'm never like surprised by this. But, I think we've seen more reporting on climate related events. We've also seen an uptick in the reporting on health as it relates to climate change. And so there's actually a metric in the Lancet Countdown to track that, which is really cool. So we're making the links more, which is good. But I think, our media tends to focus on catastrophe to sell newspapers. And there's so much good stuff happening too, right? Like there's so many incredibly positive stories about how this community has done this incredible initiative to increase the resilience, or there's this new invention that will do X, Y, and Z. And so, I get a little bit frustrated that we're not focusing on solutions. And, I think we have some neuroscientists in the room. Like, what happens when the brain hears really bad news? Like, I think there's a little bit of a shutting down versus when we hear something positive that is like innovative, our minds kind of start to open up a little bit. Right. And so I think the narrative needs to change in some ways with our media in order to help propel the movement forward, because catastrophe after catastrophe, like we just get beat down, I think, psychologically by this. But there's good news. I mean, that's the thing. We're just not reporting on it. So that's my take on it.
We've talked a lot about large scale level change, and all of that does need to happen. But I think when I hear that headline, there's a part of me that just wants to run away, because it sounds so dystopian. It's normal to feel very powerless. So one, I want to encourage everyone to find, as we hear these headlines more, find ways to take care of yourself. And also, I think it's okay to take small steps. Small steps help us build momentum. If all you do amidst your class schedule is listen to a climate podcast and then try to do that a few times a week, that can help us make progress, and can also help us feel like we have agency. So I want to make that seem okay, to take those bite-sized changes as well in your day-to-day.
I would encourage us to change the word from normal to average. So this is not normal. And we need to kind of fight back against that, because I think that normal does, if we can become resigned, right? Oh, this is the new normal. There's nothing we can do. Literally every degree matters, right? We're probably going to pass 1.5 temporarily next summer with El Nino, but then it'll back off. But fine, we're not going to keep it below 1.5, but maybe we can hover it around 2. But even if we go past that, everything matters, right? Every little bit we do does matter. One of the concepts that I've been grabbing onto this semester and trying to help my students with is this idea of avoiding narrative foreclosure. And so a couple of books out there, Generation Dread and the Field Guide to Climate Anxiety, talk about this, where we can't already have the story of the future written, meaning we have to accept new information. We have to seek out those get on Instagram. There are like 20 Instagram accounts that are like weekly positive climate news, right? And so you can see that, you can find it. You might have to do more of the work, but like keep the narrative of what the future looks like open to something other than disaster.
That was perfect. I want to take some time for audience questions. And then, so we'll take 10 minutes for audience questions, and then we'll close. Each of our panelists will have a closing statement.
Yes. Everybody's been very patient. We want to be sure that everyone here or watching by Zoom, we do have a number of people watching by Zoom, Any questions for Dr. Sorensen or any of our other panelists this time? Yeah, Carl.
So, you mentioned about the fact that mental health wasn't really well studied, but one of the shocking things that I've been reading about in the last few months is the number of mental health issues in the undergraduate population. 60% are suffering from mental health issues. And I wonder if this is in part caused by the doom scrolling, right? Literally, we're all in this loop of doom scrolling. And I don't know if there's any data on whether the 60% is due obviously it's due in part to climate change, but how much that's impacting it.
I can check. Yeah. I mean, were you talking about 60% of medical student undergraduates or just undergrad? All undergrads. Yeah. I mean, I think that, the mental health crisis that we're facing among youth in this country is huge. I sort of like to think about this idea of co-benefits though, right? Getting adolescents outside in nature, is incredibly therapeutic in so many ways. And so thinking about, that as I was a high school teacher before I went to medical school, and I would always try to have classes outside because it completely changed. I mean, I was in like a high risk neighborhood and you'd get kids outside, they'd be a little distracted for a while, but then they'd kind of settle down and they were like way more calm and frankly easier to deal with. And like, it just has this effect on people. Right. And so, yeah, I mean, part of it is like the toxic doom scrolling and so many other issues they're youth faced with. But, there still are beautiful natural places almost everywhere. Almost. I mean, in interstates, we need to get students out of them to see it. But, there's even urban gardens that you can, build in backyards that get kids' hands in the dirt and get them out from behind their cell phones and get them sort of engaged with their environment. So thinking about solutions, right? Like, yes, there's a lot of doom scrolling. How do we counterbalance that in a positive way for children, for students? Do you have a question?
So just to add a little bit more, we can see that, but we can't doom scroll with that either, right? So we see the Sunrise Movement, we see Fridays for the Future, we see these lawsuits. These are all youth-led, and when I say youth-led, I mean like 12, 13, 14-year-olds beginning this, who, some of them are now in their 20s or whatever, but they're out there, they're engaged, right? There are places that we can direct youth towards, like, look where you have that power. And some of the examples that were given in the presentation as well about like finding your joy, right? Not every 15-year-old has to become Greta Thunberg, right? But they are in a place, they have influence over their peers, they are part of institutions. There are places where they can find points of leverage.
Hi, Marika Biao, OBGYN from Advocate Aurora. Thank you so much. And Neha, kudos to you, because there's a big part of me that really kind of mourns the intergenerational inequity that is found in this. You've been this is now kind of on your shoulders, and there's a part of me that really admires it. And there's a part of me that feels like, dang, we really need to support you. So anyway, maybe you might want to follow the Garbage Queen. She's a climate scientist that puts out a lot of great positive climate news. But my question was, I think mostly to Dr. Sorensen, what steps do you think that we need to take within the health education community to standardize the training for not just physicians, but health providers in general throughout the whole work span of the healthcare provider? Thank you.
Thanks. I think about this daily. I came to the Global Consortium about 2 years ago, and it basically formed at COP25, so the Paris Climate Accords, in a side event where deans from about 60 different health professional training institutions got together and said, oh my God, we are like completely missing the mark. Like, we are not talking about this in schools. We're not educating students about this. And they formed the consortium. They said, well, we're going to all pledge, we're going to share resources, we're going to share expenses, and we're going to figure out how to train health professionals. And so what we've been doing is using this network now growing over 300 training institutions to come up with competencies to sort of say, what is it that we think health professionals need to know? What skills do they need to have? And how can we teach them? And so we have basically 5 domains that we think apply to all health professional training institutions. One is knowledge and analytic skills. The second one is around communication. How do you talk to patients, community members, interact with colleagues? Another one is on policy, leadership. How do you allow students to be able to understand how institutions function and how they can be effective? And then we have specific competencies for clinical health professionals and for public health professionals, right? They have complementary roles. And then we think about, extrapolating back from what the actions are we need the health system to take in terms of primary, secondary, and preventative care and tertiary care. And then how do we turn those into competencies? So we have a guide, and we iterate it roughly every 18 months. We send it out to all our institutions. We get feedback, we grow it, we develop it as new science emerges. And so our institutions are using these competency frameworks. And so that's great, but that's only 300 institutions, right? So how do you standardize this? And it turns out in the US that this is very difficult, because if you ask the AAMC, they say, no, we're not prescriptive. We don't say that. And if you ask the ACGME, they're like, no, we can't say what should be taught. We just sort of have these, so no one's actually taking accountability for this, because I think a lot of it is going to come down to what individual schools decide is going to be in the curriculum. So then it says, well, they're essentially, how do you teach the test, right? Because you need doctors, nurses, physical therapy. Everybody has to take a test that at the end of the day they need to pass. Same thing for currently licensed professionals. You have to do continuing education. You have to get recertified every 10 years. And so we've seen some really interesting movement there. So ACOG now has, this was because of you. How has, climate and health integrated into continuing professional education? It was because that society got together and said, we're going to do this. The same thing happened with the American Academy of Pediatrics. We have, 30 to 40 other specialties. And generally what it comes down to is a small group of really dedicated individuals in the right place at the right time with the right connections. That's what it seems to be taking. I got really passionate about this, and I'm still kicking myself as I volunteered to be a board question writer for the NBME. Oh my God. Like hundreds of hours, but I'm writing test questions now. I was like, well, if we got to teach the test, it's going to be on the test, right? So now we're going to start seeing some questions about air pollution, heat stress, vector-borne, right? So, slowly, and I don't think there's a silver bullet here. I think it's going to take small changes around. Interestingly, you look at sort of the UK, they have a totally different healthcare model, but it's top down. Like the NHS pledged to decarbonize. And we're actually working in a consultancy role with them to develop education that is not just for health professionals, but it's for all the administrators. It's across the board. Everybody is going to get this education. So different countries are going to move in different ways on this, but I see movements happening. I think AAMC needs to move on this. I think the ACGME does. I think these institutions are moving at their snail pace. They are moving, though. ACGME has a call for papers out right now on how to integrate climate and planetary health into graduate medical education. Why are they asking? Because something's coming, right? They're doing their research. And I think that's incredibly positive. So I think there's hope. And I think that all of us in our leadership positions need to create committees in our societies. We need to bring this up at board meetings. We need to ask what's happening. We need to advocate for it. And we need to support those who are in leadership positions who are taking action. So, yeah.
Okay, I think we have one question from the Zoom audience that we'll take.
I think you've addressed this a little bit, but you could probably go a little more into it if that's all right. What are 3 things that an average consumer can do to help mitigate their own carbon footprint?
Right. So, and these are things you can do not only in your everyday life, right, but at work and a healthcare setting, whatever it might be. So the 3 things that sometimes I'll give around are 1, you can eat more plant-based. 2, you can take more public transportation, which gets a little bit tough up here, right? But still, if you can reduce the amount you're driving, that's great. 3, just reduce your waste at home, right? So if you can go in bulk, if you can start to reduce the amount of plastic, and I'm not vilifying plastic necessarily, but it's certainly part of the issue, and there are better things to do than it. So hopefully that helps.
I would say focus on the big things, right? So if you focus on this every day, you're going to drive yourself crazy. So the big moments in life where we add to our carbon footprint, when we decide where to live and what kind of entity we live in. So where's your house in relation to your work? How big is your home? And how many children we have? And I'm in no way suggesting that I should have any say in that, but those are the big decisions that will add to our collective carbon footprint. And if you take time during those big moments, then you don't have to sweat. You don't have to have a panic attack in the grocery store because you can't get out of there without contributing to the problem.
And actually, it's perfect because we wanted to end with some practical solutions. So
I got really too because where's the biggest bang for your buck, right? And there's data on this. You mentioned one of them, have one less kid. That's like the biggest thing you can do. I mean, it's sad, but that's part of it. The second one that has the biggest impact is adopting a plant-based diet and minimizing your food waste. So we waste something like a third of all food that's produced. So don't waste food, eat a plant-based diet. And then the third thing is about transportation. So reducing your transatlantic or, very long flights by 1 per year, and reducing your domestic flights as well. Flying is incredibly carbon intensive. So those were the 3 things that I took out of the research that I've done in that space. So,
Neha, did you want to close with a closing statement at this point?
Sure. I want to thank all our panelists. We're so lucky to have your expertise as part of our education as students here. I wanted to say this earlier with your previous question, but because of the age disproportionate effects of climate change, if you are part of meetings, if you're part of a committee, if you're part of a society in your specialty, think of ways that you can integrate student voices or empower someone who's younger in their career. And if you are already doing that, I think that empowerment piece is very important. It's very intimidating to speak up if you're the youngest person in the room, if you don't have 10 years of experience. And we don't have time to wait for those 12-year-olds to finish college and get all their degrees. We need their voices now. So if there's anything you can do in the spaces where you have influence today to empower younger people, I encourage you to do that. And to any students, if you're interested in getting involved in the Planetary Health Report Card, please feel free to reach out. And you don't need to know everything. You can show up as you are, but we need everyone's hands on board. So we'd love to have you.
So we can start closing statements. I'll start because I don't want to be the last one. I'll let Dr. Sorensen be the last one. I think the message of hope that I would say is that we do have solutions. We need to move away from fossil fuels and towards more sustainable energy sources. And we need to support policy that does this. So that's going to be mine.
One addition I would add to Space for Action. So both of this institution, and you're all likely going to other research institutions or hospitals, is your endowment. So are you trying to address this on one hand, and then on the other hand, you're giving fossil fuel companies capital to expand production? So think about that. Big picture, think about building community, building a stronger public that works collectively rather than competitively.
I already went, but I can add one more thing. I think you've heard this throughout, but this is not a topic for climate experts. I mean, this is a topic for climate experts, but as healthcare professionals, we're so uniquely placed to speak up about this topic. I just said this previously, but I'll say it again. Please don't feel like you need to be trained for 10 years in climate or environmental science to feel like you have a role in policy or in the community. This is something that healthcare professionals, especially future healthcare professionals, need to speak up about. So I won't repeat that because it's said a lot today.
I'll add on to that in that as healthcare professionals, you have a huge influence as to what comes into a healthcare setting. And I'm talking about the products that come in there. You can instantly stop something from coming into your hospital because you don't like it. So use that. Use it in your organizations that you go on to, and really advocate for better products, less waste, things that you know are going to help the patient right now and help them when they leave those hospital doors as well.
This is great. It's hard to go last. I love this quote. It just says, we didn't leave the Stone Age because we ran out of stones. We left because we found a better way. And so we don't need to wait. There's better ways. So.
Yeah, I'm gonna just put this up really quick.
All right. All right. So I'm going to start us with just some final thank yous. So first of all, thank you for everybody for the engaging discussion today. An extra special thank you to our keynote and panelists and moderator for their excellent points and tips and recommendations. I think we all can learn a lot from this. Additionally, Dr. Elliott, Dr. Calkins, and I would like to thank our WISH team, who are pictured here on the screen, as well as our WISH Advisory Committee, the Administration and Board of Trustees at Rosalind Franklin University, for their continued support. So thank you all for everything that you do. I'd also like to take a quick moment to advertise 2 events that we have coming up. The first is the Chicago Medical School's the Symposium on Race and Medicine, Maternal Mortality and Nation in Crisis, which is next week on September 20th. This is a hybrid event, which will take place both on the main RFU campus as well as being held virtually. And second is our next WISH event, which is our WISH part of our WISH seminar series with Sabatu Mansoure, who is the CEO and founder of the Mansoure Foundation. This is on in January 17th, 2024. And sorry, my slides skipped ahead. And this will be a Zoom webinar on global maternal morbidity and mortality. So please join us on Zoom. She'll be joining us from Tanzania. So. And then finally, just want to say thank you to all who attended this afternoon, both in person and on Zoom. We had quite a great Zoom turnout, so I'm really thrilled to see that. Have a lovely evening, and we hope to see you again at WISH events in the future. Thank you.